Hello, good evening. Hi, this is Dr.V. I want to welcome everybody that has been following these lives, whether it's this live here or the Wednesday lives through the CNY Fertility channel. So today, I was asked to talk about polycystic ovarian syndrome. Because we are in the Polycystic Ovarian Syndrome Awareness Month. So, what is PCOS as it's normally known by the acronym? So, polycystic ovarian syndrome or polycystic ovarian disease, like the word suggests, is the ovaries with a lot of cysts. So, what does that really mean? That means that the way that the eggs are actually formed are cysts, okay? Follicles are functional cysts in the ovaries that will eventually become an egg, will eventually create an egg, because actually the follicle will burst like a bubble and the egg comes out from the follicle. The people with polycystic ovarian syndrome, instead of having a normal ovarian function where there's a bunch of follicles recruited, but then one or maximum two leaf follicles keep growing and the other ones regress, they just keep sort of recruiting, and there's not that differentiation with a lead follicle. So they create all of these cysts that don't regress and they just stay there. They don't ovulate, and then at the same time those cysts stay there. And I have personally seen very severe cases where the cysts they look like a bowl of grapes. I had a patient a few years ago that after she was done with reproduction, she just kept creating like massive cysts, a severe case of PCOS, and she opted to actually take them out. We went in and did drilling. We did partial removal of the ovaries at one point, and finally she asked me just take them out. All of the complications of PCOS were really bad for her, and she was obese, and so that didn't help the whole cycle. So going back to what is PCOS, there's a few risk factors for PCOS. It is not fully understood the pathophysiology of the disease, but one, it tends to run in families. So you can see it in twin sisters, especially if they are identical. They tend to both have PCOS. You see them in families, first degree relatives, moms, sisters. They tend to be more prone to that. There's another few risk factors that have been associated with tendency of PCOS. So one, environmental. If there was any reason why the mother was exposed to excess testosterone in pregnancy, then the child might be at more risk. Use of valproic acid, which is a medication for epilepsy, for seizures, among other. So if the mom was exposed to that, then that baby, if it's a female baby, tends to be more prone to PCOS. So those are a few things that have been associated with the syndrome. Now, what is the syndrome? Now, I need to explain that the endocrinological system is all intertwined. So PCOS is no exception, being mostly ovarian related. So it is a diagnosis of exclusion. You need to verify that there's nothing else in that very intertwined machinery that is not working right before you give somebody the diagnosis of PCOS, because some of the other diagnoses are a lot more serious than the PCOS diagnosis, and they need to be found and addressed. And in nature, and especially in our biology, our body biology, there's no black and whites, okay? It's kind of a gradation. So you have completely functioning ovaries, and then severe PCOS, and there are gradations in the middle. So you can have some criteria, not quite have the disease, just the same way as maybe your doctor could say you are pre-diabetic and not diabetic, but you're in that spectrum. All right. There's 3 criteria necessary for diagnosis, and different groups agree on different things. They're based on the Rotterdam criteria. Like the American Gynecological Association decides one thing, another, but they all are based on that. 1, you need to have irregular periods. So that is a sign of anovulation. Like I was describing, they recruit but don't ovulate, recruit and don't ovulate. So they tend to have irregular cycles because they don't ovulate every month. And in severe cases, they don't have a single period a year, okay? 2, you have to have signs of male distribution of hair because of high testosterone, high androgens, all right? So, and that also includes acne, anything that shows high testosterone. So acne, facial hair, hair loss, okay? Male pattern of hair distribution, hair in the wrong places. So for example, female genitalia is usually triangular in hair distribution, while male genitalia is more of a rhomboid, okay? So all of those things are part of the criteria, and sonographic finding of multiple little follicles around the ovary. They look like a purse string, and that's actually the sonographic term for it, with at least 12. We usually don't count them, but you see it, all the little follicles, one next to the other at the edge of the ovary. That also is an inclusion criteria for PCOS. So those are the main criteria. You need 2 out of 3. Usually the first 2 are critical, meaning the clinical presentation, irregular periods, and signs of high testosterone, and then the sonographic findings to back that up. And then you have the secondary findings. 1, insulin resistance, okay? So in that diabetes, pre-diabetes spectrum. Inverted ratio of FSH to LH hormones, and I'll go into that in a little while. Those are some of the other criteria: high blood pressure, obesity. Even though we can have PCOS on thin women, I've seen them, but those are associated symptoms, associated second categories that could go with the PCOS diagnosis. So those FSH LH ratios, what does that mean? So I was saying that in PCOS you start recruiting and you don't ovulate, and that is because you have high LH, which stimulates the cells of the ovaries that are called the T-ca cells, that produce testosterone, okay? Testosterone can be converted to estrogen in the granulosa cells, but you need FSH for that, all right? So then it's almost like you have excess raw product and you don't have the next stage in manufacturing, because then your FSH is not higher than your LH, right? Also, having between the LH being high and the insulin resistance, your sex binding globulin, so the proteins in your blood that transport testosterone are low. So then that complicates matters even more, because when the testosterone is attached to those proteins that move it around, it's inactive. So not only you have high testosterone, but you have it all flowing in the blood, so it's like a lot of active testosterone, which makes things a little more complicated. When women tend to be on the heavier side, they will make peripheral estrogen, okay, because fat does have aromatase, which is an enzyme that converts testosterone to estrogen, especially estrone. But then you have an even more interesting scenario, because now you have high testosterone. That is part of the of the syndrome, and now you have high estrogen. So everything is high, and then the high estrogen puts those patients at risk for especially endometrial cancer. And that's beside all of the fertility challenges that they go through because of the hormone imbalances, as well as the fact that they don't ovulate every month. So I see a lot of PCOS patients in my practice at different levels. When I'm working through CNY in the fertility world, well, they don't ovulate, and when they do, sometimes the egg is not mature enough. So a lot of things happen with fertility in that syndrome. And then on the GYN side, we're dealing with the endocrine derangements, meaning, girls don't really want to have a lot of acne, facial hair, or hair loss, or, the heaviness, PCOS patients, because of the insulin resistance and all the metabolic syndrome and everything that's happening in their body, they tend to have a really hard time losing weight, especially when they are on the heavier side. So then I help those patients deal with controlling their condition and trying to make it as normal as possible. So I have a few questions here. So Glenda, I'm testifying of the miraculous work of a great traditional doctor. I've been suffering for herpes. Okay. That's awesome, Glenda. I'm glad that you're feeling better. Miss Taylor mentions, will PCOS go away or be cured? No, it's really managed. Now, like I was saying at the very beginning, all of the endocrinological scenarios or challenges, right, are gradations, and you can actually, with lifestyle modification, you can actually switch to a milder side. But the predisposition will always be there, and that is some of the stuff that I'm going to go into, because I had a question through the blog about people having confusion with the diagnosis. This doctor said I had PCOS. This doctor said I did not have PCOS. And part of it is depending on what that person is doing, that they can revert to having normal periods. So as they, for example, gain weight or go through pregnancy and their bodies changes, then if they're closer to the spectrum that it's more severe, then the PCOS gets worse. If you go the other direction, their bodies will work almost normal. And I have a lot of patients that actually with PCOS, by losing weight, changing the diet, taking even supplements that will help their bodies regulate, they get pregnant on their own. So you manage PCOS, okay? Let's put it that way. It's not like you're cursed with PCOS or cursed with diabetes. It's more like you have that predisposition that you have to manage, okay? In certain occasions, especially the women that are thin with PCOS, it's almost like the genetic component is very strong, and those patients need to work a little harder than the heavier PCOS patients. So going back to the diagnoses of exclusion, because I want to point that out, it's so important to understand how the endocrine system is a system, okay? And one organ is linked to the other and will affect its functionality. So that's one of the reasons, and I know, especially in the fertility clinic, I get a lot of questioning of why do I need to do all this testing? And it's to kind of discard some of the other possibilities and, treat you the wrong way, essentially. One, we have to make sure that there's nothing wrong with the pituitary, okay? So the endocrine system starts at the level of the brain with the hypothalamus, all right? And then you have the master gland, the pituitary. If there's an issue with the pituitary, the most common tumor is a prolactinoma, okay? So most of them are benign. Prolactin levels will be up, and it can show as irregular periods and heavy set and some of the other issues found in PCOS. So that's one of the reasons we check on that. The other thing that we check on is the adrenal gland. The adrenal gland, it's also very important for ovarian function, thyroid, and it does produce testosterones. The real word for that is androgens, because it makes DHEA, and it has a precursor even higher up, which is the 17-hydroxyprogesterone. So one, we have to verify if that 17-hydroxyprogesterone is elevated. We could be dealing really with an adrenal issue, congenital adrenal hyperplasia, that can present in an adult onset, especially in the 20s. Okay, so we need to start discarding all of these other things. The thyroid, if your thyroid is off, your lipid panel will be off, your cholesterol will be crazy. You can have, menstrual issues as well. Like I was saying, the adrenal might go a little crazy. And you can present with hair loss or acne. And it's not necessarily because your testosterone is elevated, it's because you could have a thyroid disorder. So we need to check all of those things before we jump into PCOS. And of course, nowadays, we can do kind of all at once and do an ultrasound, and usually PCOS patients will have the classical ovary with a lot of cysts. That is one of the Rotterdam inclusion criteria I started mentioning before. So Ashley is asking me, yes, so having thyroid issues can mimic PCOS. It won't make you have PCOS, it can mimic PCOS. Thyroid, adrenal, or the pituitary can mimic PCOS, have similar scenarios, similar symptoms at presentation, but then the etiology, meaning the reason for the disease, it's not linked at all. PCOS patients have PCOS at the very beginning. A lot of times, even as teenagers, they never get regular, they start gaining the weight, they tend to have worse acne, facial hair early on in their 20s. So you don't just have PCOS at 25. That's not how this works. You see the signs early on in puberty, and most patients know that they have PCOS. Some of the patients that get to me, they have wrong diagnoses. A lot of time, doctors will see somebody that has irregular periods and can't get pregnant, and they just say, you have PCOS, or they tell the patient you could have PCOS, but they don't really meet criteria once you go through all the laboratory and radiologic testing to verify if that is correct or not. Okay. Now, when does it get confusing for patients and doctors is when the patient does not have necessarily a severe case, and she goes through periods where everything seems to be normal. That's when it gets a little tricky. So how can we discern that? One, laboratory testing. So we can follow a few cycles in that patient and get baseline and see that LH to FSH ratio at day 3 of menses. Also, to see if it's a true ovulation cycle, not because you have a period every month or every month-ish. Let's say your cycle's 40 days, so it doesn't seem that crazy. Well, are you really ovulating? So then we would check day 21 progesterone at the very least to verify if you ovulated or not. And history, were you regular all the time, or, how were your periods in puberty? Now, I will mention that from the time of that first period, there are 2 to 3 years where that endocrine system is naturally immature. So if a girl gets a period 12 or 13, those first few years, her body is still adapting and is still developing. So we cannot label a 14, 15-year-old girl with none of these, female endocrinological disorders, because she's still immature. We reach sexual maturity at 18. I have a bunch of girls around. For those who know, I have a mother of 5, and I've seen how even after having that first period, they keep growing. Their secondary characteristics like breast and shape and stuff like that will continue to evolve and kind of taper off at 17, 18. Okay. I have been completely unable to shed 12 pounds of residual baby weight. My period became irregular after giving birth to my 3rd child. Could this be a sign of PCOS? Again, we don't just develop PCOS in the middle of our lives. There could be something else happening. If suddenly you were having irregular periods, it's your 3rd child and you can't lose weight, we need to check the other things I was saying. Are we dealing with prediabetes? That's not necessarily related with PCOS, even though PCOS is related to that. Okay. Are we dealing with any disorders in the pituitary or hypothalamus? Are we dealing with the adrenal? Are we dealing with the thyroid? Are we dealing with even candidiasis? Okay. We as a nation eat a lot of carbs and sugar, and that tends to take our gut flora and flip it to have high levels of yeast and candida, which will present with that weight that you can't get rid of, and other symptoms that are fatigue and such and so forth, that is very similar to the thyroid, as how the thyroid presents when there's a decrease in functionality in the thyroid. So we need to check. We can't jump into a diagnosis of PCOS, especially on the 3rd child. So that means that you had all these years where nothing showed up, and then this showed up. It's very, very unlikely that that is the true diagnosis. Ms. Taylor is saying, what is the surest sign of PCOS? Irregular periods. Irregular periods. It could be seasons of irregular periods, meaning that is the most common finding. Like that's the most common scenario I get in my patients, where it's like, oh yes, I was irregular as a teenager. Then I was put on birth control. Then I stopped the birth control, and then I got regular for a while, but then I got irregular again. But seasons of irregular periods with any signs of male pattern of hair distribution or high androgens, so high testosterones, are the 2 criteria that are the most important ones. So now let's briefly talk about what to do with PCOS. If you're not trying to get pregnant, okay, then we talk about trying to level out those hormones. And the best thing is to be on birth control pills, because birth control pills increase the sex binding globulins. So that way, even if you have high testosterones, it will be stored inside those proteins and it won't be active. So with the birth control pills, one, we do decrease the activity in the ovaries, therefore the testosterone goes down and the estrogen levels stabilize. But also by binding it, we decrease the activity, and then we're going to have a decrease in symptoms like the hair loss and the acne and so forth. There's some birth control that will actually have a progesterone in it that will have a androgenic effect that will then decrease the effect of the testosterone even further, and it's very good for especially young adults with acne. Okay. Now, once we have that under control, then we can look into, the cosmetic aspect of things, because it's very traumatic for a young woman to have all the scars or the hair. So for scars, we can do microneedling, PRP, microdermabrasion. And then for the hair, we could do laser hair removal or electrolysis to get rid of that hair, because once the hair becomes black, we have to destroy it. Okay, so prevention is key. Same thing if there's any hair loss, sometimes just by putting them on birth control, it helps. Otherwise, we could do PRP or laser stimulation so that they can get their hair back. A lot of times, if the birth control is really helping with the hormone balancing, it becomes a lot easier for them to lose weight. PCOS patients do fantastic on keto diets. They really need to cut down on their carbs. They tend to have insulin resistance and metabolic syndrome, and they don't really process carbs very well. So those lifestyle changes could be life-changing. Okay. If they're trying to get pregnant, PCOS patients do very well with oral ovulation induction. And usually we combine that with metformin, which is a diabetic medication, to cause increased sensitization of the insulin at the level of the receptor. And some of those cascades of events get kind of diminished because the insulin issue is the one that's linked with decreasing the sex-binding globulin. So by correcting some of that, and hopefully the patient is going to get on a low-carb diet and doing ovulation induction by mouth, a lot of times the scenario is corrected. There's some PCOS patients that don't ovulate on oral medication, and then they do need to go to a fertility specialist and go into injectable medication and very close monitoring to get them to ovulate. A lot of times that will correct the problem. But if it doesn't correct the problem, we would be talking about IVF. And then IVF in those type of patients, because their ovaries are overly sensitive, in most cases, we just have to be very gentle in how we stimulate them, because they tend to create a lot of eggs and a lot of immature eggs. So I see it sometimes where you have an egg retrieval that's 30 eggs, but 20 were immature and useless. So it's a tricky scenario if we get to that point. But in the PCOS world, we have a subgroup that are really, really, really resistant. So usually they don't ovulate on oral medication. They tend to be even a little resistant to the injections. Regardless, those patients need to be monitored very, very closely through their fertility journey so they don't have other complications. All right. Well, today it was a pleasure talking to you and answering some of your questions. I wish that you're all very blessed. You're always welcome to join me and talk to me through my messenger and Maribel Verdiales. And may you all be very, very blessed. We shall continue this journey together. Bye-bye. Okay. My computer doesn't want to turn off. There you go. Bye.